Okay, so Dr. Hassan, are you ready?
Oh, yes, doctor.
Okay, your time starts now.
Hello there. I'm Dr. Tasmim, one of the medical doctor of medicine outpatient clinic today. Can I confirm your name, and address, please?
Yes, doctor. I am Miss Alina, 24 years old.
Nice to meet you. And how can I help you today?
Yes, doctor. Basically, I have been suffering from some fatigue for quite a couple of months. That's why.
And from notes that I have been also informed, you are suffering from a right arm pain, right?
Yes.
And Miss Elena, could you please tell me a little bit more about your complaint? I mean, actually, what do you mean by fatigue?
Actually, doctor, I have been feeling more tired than usual. There is a bit lethargy, malaise. I don't have any energy left. It feels like generalized body aches and pains all over my body for the last 6 months.
And do you notice that you feel tired, particularly towards the end of day?
No, doctor, it is almost all over the day and night, 24 hours.
I'm so sorry to hear your sufferings, Elena. And what about your right arm pain?
Yes, doctor, it has been there for quite a couple of months and it bothers me.
And I'm so sorry to hear that. And how did it start?
It started gradually.
And day by day it is increasing.
Yes.
Do you have similar kind of pain in your left arm or legs as well?
No, doctor, it is only in my right arm.
And do you notice that you are experiencing changes of your finger when exposed to the cold?
No.
Okay. And what makes worse your right arm pain? I mean, taking
Uh,
any activity.
No, doctor, no activity. It is always there. I haven't noticed any aggravation or something like that.
Okay. Did you try any medicine to relieve your right arm pain?
Yes, doctor, I tried some certain over the counter medication as well as some homeopathic medications and some painkillers. But this pain is always there.
I'm sorry to hear that. And does this pain awake you from sleep at night?
Yes, doctor.
Okay. And along with your fatigue and right arm pain, do you notice that any unintentional weight loss?
Yes, doctor. There is
Oh,
almost 5 kg in 6 months I have lost.
I'm so sorry to hear that. And what about your appetite?
Doctor, appetite is also decreased. I don't feel like eating. I don't like anything.
And do you notice any high body temperature?
Sometimes, doctor, there is high body temperature as well.
What is the maximum recorded temperature?
It is only, doctor, 100 degree.
Okay. And does it stays all the time with you?
Doctor, it is sometimes there, sometimes not.
Okay. Do you notice any lumps and bumps?
No.
Okay. Do you feel dizzy when you raise your arm above the head?
No.
Any history of blackout before?
Not blackout, doctor, but actually, what happened? I suffered from the sudden loss of vision for almost 4 months ago, and that sudden loss of vision came back after 10 minutes. So it was not blackout. It was only loss of vision
In your right eye, right?
up in both of my eyes.
In both of your eyes. Okay, okay. All right. May I ask that are you suffering from any long-standing medical condition?
No, doctor. Apart from this loss of vision, yes, I have been suffering from increased blood pressure for 5 to 6 months almost.
And any other medical problem apart from high blood pressure?
No,
Any past medical history?
no.
Any history of past surgery?
No.
Any important family history of note?
Uh, yes, doctor. My mother has been suffering from a joint condition which is called as I think rheumatoid arthritis, and my sister has been suffering from lupus.
I'm sorry to hear that. And may I see the medication list?
Doctor, apart from paracetamol and some homeopathic medication, I have been on Ramipril for this increased blood pressure, but there is no benefit of any of these medications.
Are you regularly compliant to this medicine?
Yes,
Do you take regular follow-up on blood pressure clinic?
yes, doctor, but it is always high.
Do you have any history of headache?
Yes,
For how long?
4 to 5 months, on and off. Sometimes it is
Uh,
there, sometimes not.
Specifically, which part of the head?
It is all over the head, doctor. I cannot localize.
And what about the intensity from 0 to 10?
It is 4 to 5.
Okay, and what makes this worse?
Nothing.
Or what makes it improve?
Sometimes rest, sometimes sleep.
All right. And do you have any history of chest pain?
No.
Any racing, pacing of your heartbeat?
Yes, doctor. Sometimes there is racing and pacing of my heart.
For how long?
4 to 5 months.
And it is irregular or regular?
I'm not sure, doctor.
Any breathing problem?
No,
Any history of cough?
no,
Coughing of blood?
no,
Any history of joint pain?
no,
Any history of rash?
no,
Any history of mouth sores?
no,
Any history of hair fall?
no,
Do you smoke?
no,
Do you drink alcohol?
no,
Do you use party drug?
no,
Asking some private questions. Are you in a long-term relationship?
no,
Uh, any history of casual contact?
no,
Do you take birth control pill?
no.
For about a period?
It's normal, doctor.
Do you drive?
Yes.
Actually, as you have one episode of vision problem and has also history of arm pain, would like to suggest to stop driving for a while. And may I know that any family history of blood clot
No.
or okay? Is it all right if I talk to do physical examination?
Yes, doctor.
Well, I'd like to check the pulse of the right hand.
There is no pulse, doctor. You can't
Uh,
feel.
okay, would like to check the symmetry on the left end.
Yes, it is regular and 78 per minute.
Okay, I'd like to check the pulse, also brachial arteries of both arm, and looking for any discrepancy.
It is normal in the left arm, but it is diminished in the right.
Okay, I'd like to measure the postural blood pressure.
Uh, Sorry, doctor, what?
Postural blood pressure, postural drop.
Okay. First, you will check the blood pressure on the right side now.
Yes,
Okay, on the right side, it is 130 by 150 by 90.
on the left.
130 by 90.
Okay, then would like to check the subclavian bruit and carotid bruit.
Yes, carotid bruit is there on the right side, but no subclavian.
Okay, okay, all right. Would like to check the precordium, looking for any murmur present or not, particularly allodysplastic murmur.
Yes, doctor. How will you check it? In which area and which maneuver?
Actually, I'll tell the patient that please sit up and leaning forward and take deep breath in and then out for me. And I will check it in new aortic area. I mean, left third and fourth interstitial space.
Yes, doctor. It is present, exaggerated in expiration, and leaning forward position.
Okay, would like to check the base of the lungs, looking for any cracks present or not.
They are clear.
Okay, would like to check the eyes, looking for any anemia present or not.
No conjunctival pallor.
Okay, all right. And then, do you have any tummy discomfort?
No.
Do you have any history of yellow discussion of the eyes and urine?
No.
Okay. I'd like to check the hands, looking for any evidence of Raynaud's phenomenon or Raynaud's disease present or not.
Yes, doctor. No Raynaud's.
Okay, would like to check the pulsation of in her legs. I mean, arterial dorsal spadius, then posterolateral.
Hmm. They are normal, palpable, comparable on both sides.
Okay, do you have any weather preference?
No.
What about your mood?
Sometimes it's not good. Otherwise, it's okay.
Okay, we'll involve the mood doctor to help you in this regard. And what do you do for living?
Actually, doctor, I am a teacher.
How all this is affecting your daily activities and job?
Yes, doctor, it is impacting quite a lot. I have no energy left.
Okay, I'm so sorry to hear that. And do you have any history of pain in your legs?
Yes, doctor, I have pain in my ankle basically. Both of my
Uh,
ankles.
both your ankles, right?
Yes.
Okay, may I see your ankles and looking for any evidence of arthritis present or not?
Yes, doctor, no arthritis.
And no discrepancy in pulse, right?
No discrepancy.
All right, all right. And do you have any walking difficulty?
Yes, doctor. Basically, because of this pain, I have difficulty in walking, and this pain just subsides when I sit down.
Okay, all right. And I'd like to check the renal bruit as well.
Yes, doctor. Renal bray is not present.
Okay, okay, all right. And
2 minutes are left.
uh, all right. What is your concern, Miss Selina?
Actually, doctor, what is going on with me?
After taking history and do physical examination, most likely you are suffering from a medical condition called Takayasu arthritis. So don't bother the term. It happens due to problem in the defensive system who should attack the foreign particles and bug. But in your case, it causes soreness of large blood channels in different parts of your body, which
Hmm.
is why you are experiencing this kind of feeling fatigue, right arm pain, and one episodes of vision problem and the leg problem as well. So we'd like to run some routine blood test, do some necessary scan test. After confirmation or diagnosis, Miss Elena will form a multidisciplinary team, which includes joint doctor, other group of specialists, including physiotherapist and occupational health care worker, to provide you best care of management. Any other concern?
Is it curable?
Actually, Miss Elena, it is a, manageable condition. I mean, it is treatable, but it is not curable one. And would like to give you our regular follow-up in our joint clinic. Will that be okay with you?
Okay, doctor. Will you admit me today?
Miss Helena would like to, we wishes to run some test and imaging, but right now hospital admission is not required, though I will talk to my consultant. Any other concern?
Does it run in family?
Actually, people suffering from this kind of medical problem, there is in case chance to having the same problem others family members, though it is not a familial health condition. Any other concern?
Time is over, doctor.
Thank you.
Okay. So, Dr. Hassan, can you please tell me your positive findings
The
in the
positive findings
history?
from the positive findings from history, Ms. Elena, 24 years of age, presented with fatigue and right arm pain for the last 6 months. She has history of feverish feeling or fever over the past few months, has high blood pressure, which is difficult to control. And she's taking on blood pressure lowering agent as well as some homeopathic medicine. She has one source of vision loss in her both eyes around 6 months ago. She has pain in her um, ankles predominantly and need to stop after walking to get rest. From physical findings, I appreciated that she is anemic, pulse is diminished in right hand and right. The brachial pulsation is also diminished. There is a carotid boot is present and early diastolic murmur is present. Another issue is that patient has on and off history of headache over the past few months, 4 to 5 uh, grade in intensity, and she has a history of weight loss as well. So all these points towards a diagnosis of Takayasu arteritis, and possible differentials could be cervical rib for her right arm pain, could be peripheral vascular disease as well as a possible differentials for right arm pain.
Hmm. Okay. Any other differential?
Ma'am, need to exclude other vasculitis.
Hmm. Okay. So how will you investigate?
Investigation will be, ma'am, angiography of the aorta and its branches, duplex study of the neck vessels as she has a carotid void. Want to do complete blood count looking for any abnormalities, inflammatory marker, ESR, CRP. Then liver function test, renal function test, urinary fasting blood sugar, chest X-ray, ECG,
Hmm.
echocardiography.
Okay. And how will you manage?
Management will be a multidisciplinary team approach, which includes a rheumatologist, then a physiotherapist, occupational healthcare worker, specialist nurse, and other allied healthcare professional to provide her best care of management, non-pharmacological management, patient education, counseling, reassurance, regular follow-up on joint clinic, pharmacological management, ma'am, initially steroid and later steroid sparing agent can be tried. And to control her and treatment of her underlying comorbidities such as blood pressure.
Any surgical management?
Yes, ma'am. Reconstructive vascular surgery after consultation from a vascular team.
Okay, doctor. Time is almost over. So, overall, it is a very good attempt. Let me give you a feedback and then we will discuss certain things. Okay.
Okay, ma'am.
Okay, Dr. Hassan, your feedback is almost ready. And
Okay,
let
ma'am.
me share you it in the group,
Okay.
and you can see it now. Just for a few things, I have given you borderline in clinical communication. Otherwise, any examiner can give you full marks in that as well. Uh, I haven't written any comment because I wanted to share it verbally. Your history taking skill is very good, and your time management is also very good. Just I want to say that try to be a bit systematic. Like I would say that complete your history first, then do examination. And for example, if you feel like that no, you will keep on taking the history questions and you may lose your track, you can skip some of those, do the examination, and after examination come towards the patient and ask the further questions. And then when the examiner say 2 minutes left, then you can carry out the part of concerns. But what happens in the international centers, mostly the patients are not the history narrators, they are the surrogate. So first you need to take all the history from the surrogate, then examination, and then concerns now. So this was a bit thing which I noticed, that you asked about intermittent claudication quite late, because yes, this is a tricky scenario. But uh, here I just wanted to tell that I put myself that this patient has right arm pain, there can be left arm pain as well. And whenever it is such a similar scenario, always whenever any scenario, I would say, when you are checking for pulse on the right side, always compare on the left side as well. As this scenario was quite evident, there was some vasculitis, some sort of connective tissue disorder or something like that is going on now. So Dr. Hassan, are you there?
Yes, I'm doctor.
Okay, so one thing I want to tell you here is that when you started the scenario or when you started your consultation, again, the same thing I would just suggest that try to start with some good sentence in order to just build the repo, that you can say that okay, I have been asked to take your medical history, I will do your examination. Or for example, if it is a surrogate, I will take the history of your brother or sister, and then I will do her examination, and I will be more than happy to answer all of your concerns, if that is okay with you. And meanwhile, I may write few notes. And I will also suggest you that try to make it a practice that you write all the points in your history, and the examiner will not mind if you narrate the history by just looking on the paper, because there is so much less time now, and we should tell each and every positive finding to the examiner. For example, here you asked almost all the positive findings, but when you were telling your positive findings to the examiner, you missed quite a couple of things. For example, anorexia, weight loss, or palpitations, or you can use the term, for example, intermittent claudication to the examiner. When you are talking with the examiner, you can talk about the medical terminology. There is no such jargon when you are giving your viva. Okay, so it is very good that you immediately got this case in the start. But when you were asking about constitutional symptoms, I would suggest that ask all the questions there. For example, you haven't asked about night sweats, they may be present in such patient. Okay, and rest, I think you covered each and everything. Just a few things which which I noticed is that yes, you asked about the skin lesions. I deliberately said that yes, no skin lesions are there, because sometimes they can be quite misleading, because there are certain patients of Takayasu where they have uh, skin lesions like erythema nodosum or pyoderma gangrenosum, or some non-specific skin lesions as well. All right, and rest you have covered each and everything quite well. You asked about past history, but I would suggest that since you catch your diagnosis, or at least you were thinking about that diagnosis of vasculitis, you should ask about all the questions. For example, any previous surgery in the past, any previous hospitalization. Okay, it is very good thing that you are very much fluent in your history. You don't have to think that what will you ask now. You don't have to say these sentences any history of, and during saying any history of you think that what question you are going to ask now. This is very good thing. Okay, now I would suggest that instead of postural drop here, blood pressure difference is more important. Okay, and you will check the BP difference in both arms. And when you check that there was no pulse over here, carotid, then you will go towards the brachial. After brachial, you will go towards the carotid one by one, because we know we will not palpate both the carotid side by side. I mean together. You will check carotid once and then other, and then you will auscultate for the bruit over there, right side as well as left side. After that, it is up to you that you want to complete your peripheral examination or you will go sequence wise. For example, when examiner will not deduct your mark, but they will just want that just like you took the history in a slick manner, your examination should also be slick and a bit organized. For example, here you will you are going to checking for the peripheral pulses. When you are coming down, you will check for dorsalis pedis, compare on both sides, posterior tibial, compare on both sides. Then you will come towards the popliteal artery. Okay, after popliteal artery, you will come towards the femoral. You will auscultate, you will palpate the femoral as well. Obviously, after taking permission from the patient, and here you will not palpate now, because what happens, basis examiners don't like that you palpate the patient from the clothes. You will offer your examination at the same time, that you will say that okay sir, I want to auscultate, I want to palpate the patient femoral artery. Or they may say okay doctor, or they will say okay, proceed next step now. Here then you will come towards the renal. You will know that okay, there will be no finding in the tummy of this patient. I have to complete the precordium examination, because you in the exam you have to make the proper exposure as well. So try to do the precordium examination in detail. I mean inspection, because since you will have to find aortic regurgitation murmur here, so you will look for any visible pulsations, displaced apex beat. Also you will look for any palpable thrill. I think you mentioned something 4 by 5 grade. I was not able to understand. Was that the grade of murmur?
No, ma'am. You have told me that the headache
Okay, okay, that
4 to
was
5.
headache. Okay, okay, fine. So, for example, here you will not find the thrill. You will not say 4. You will just say, okay, 3 by 5, 3 grade 3 murmur. No need to tell about 3 by 5. Just say grade 3 murmur of early diastolic murmur, which is exaggerated in expiration when the patient is in lean forward position in the left second intercostal space. And then you will tell about your further findings. Left parasternal heave or JVP or any hyperdynamic circulation you can get. For example, here you didn't find any renal bruit. Similarly, no other, I mean peripheral signs of aortic regurgitation. Okay, so after that you will, rest of your examination is quite okay. One thing you should offer at least, eye examination. Okay, here, because since the patient has been suffering from hypertension, although she know only that she has been suffering it from 6 months, but still you will offer fundoscopy here. And after that, in differential diagnosis, okay, it was a good approach, but you can say that it can be a case of when you were trying to say about cervical rib now. I hope you were trying to say something about thoracic outlet syndrome or subclavian steal syndrome. They also can present in the similar way. They can also be in the similar unilateral symptoms. All right. And let me tell you one thing. I just remember that this case has come in the PACES 23 died, I mean last died of last year in Pakistan Center. Okay. And when you were telling about investigations, I would suggest that in long case, you should tell your investigations from starting from general. But in short case, you should tell about specific, because I have seen feedback of certain candidates in which the examiner have written that the candidate started his investigations from imaging and their marks were less. So it depends upon the examiner. But here, the most specific, or I would say not the most specific, but most, uh, suggestive investigation is ESR. Because instead of jumping towards the imaging or invasive investigations, ESR can give us a quite a clue, because it is also a clinical confirmatory diagnosis now. So ESR more than 50 is a good clue towards this diagnosis of vasculitis. Then it's good you tell about the complete blood count, but I would suggest that instead of telling about renal function test or liver function test, because some examiner may say that the candidate is over investigating the patient. So, whenever you are telling any investigation, you should have a good logic behind. You should know that what you want to check in that investigation. For example, ESR, it should be high, more than 50. C-reactive protein, it should be high. In CBC, I would just look for anemia or WBC's response. CBC, you can fit in every case. Now, you can say anemia or WBC's response. And after that, you can say about workup for any associated connective tissue disorders. For example, I would go for anti-nuclear antibody, RA factor, or any ANCA antibodies. This thing you can add. Or you can even say about HLA typing, because it can also have association with vasculitis. And then you will say that, okay, now I will come towards in imaging, in which I will perform carotid Doppler ultrasound, CT angiography, magnetic resonance angiography, in which I would like to look for thickening of the vascular walls. And then you can say that, okay, I will also go toward the invasive investigations, like okay, invasive angiography of aorta, for example. And in your management plan, you should start from general management. Always tell about patient education, counseling, and explanation of the disease. Multidisciplinary team management, which will involve rheumatologist, cardiologist, cardiovascular surgeon, vascular surgeon, as well as specialist nurses, and blah blah. And then you will come towards the uh, uh, for example, here in the general management, you will say that yes, you told very well that I will try to manage the comorbids of this patient, for example, hypertension, and she has also suffered from previous episode of transient ischemic attack or MRCPUK, and I will also try to minimize those cardiovascular risk factors by lifestyle modifications, as well as through certain pharmacological agents. For example, in pharmacological agents, I will go for corticosteroids, which are the mainstay of therapy in the form of oral corticosteroid prednisolone. And since I have to give it for long period of time, I will also give the patient bone cover as well as GI cover. And next treatment options will be steroid sparing agents, for example, methotrexate, cyclophosphamide. And then I can also give this patient a TNF inhibitor therapy like etanercept, infliximab, anti-CD20 antibodies, rituximab, interleukin 6, tocilizumab. Because there are certain candidates who are very much good in theory, and there are certain examiners who are very much good in theory, and they focus on these things. So just try to remember corticosteroids, steroid sparing agents, methotrexate, only name of these things. They will not go in further detail, neither side effects nor doses. Just try to memorize those names: tocilizumab, interleukin 6 inhibitor, or anti-CD20 antibody, rituximab. And then you will come towards multidiscipline sorry a surgical treatment. In surgical treatment, you will say that yes, I may involve the cardiovascular surgeon, vascular surgeon, sorry, and they will go for angioplasty either with or without stenting, and surgical revascularization, bypass graft surgery, etc. All right, there can be some more questions for you from the examiner side. For example, they may ask from you that what could be the cause of hypertension in this patient. Okay, Dr. Hassan, what could be the cause of hypertension in such patient?
Ma'am, narrowing and coarctation of the vessels,
Mhm. Any specific vessel?
probably subclavian.
Okay. But mostly it is because of renal artery stenosis. Because
Sorry, sorry, renal.
renal artery, yeah, renal artery stenosis, when as the renal artery will become more stenotic, kidney will sense it, and it will think that the blood pressure is decreasing, and it will start producing renin, and hence there will be more angiotensin 2, and hence it will lead to hypertension. But most of the cases, species examiners do not go in the detail. It will only be there if, for example, you will tell your history examination and cover each and everything, and still your time is remaining, then they can ask such questions. But it is mostly not the case. All right. So overall it is a very good attempt. I just made a uh, small presentation of Takayasu arthritis, which I want to share with you people. Just give me a second.